Good afternoon, everyone. Thank you for your patience in letting me set up, as always. We're going to talk about one of my favorite topics, I guess, which is septic cardiomyopathy. Why is it one of the favorite topics? Because we see it all the time. And I think probably one of the things we need to be very clear about when we're talking about septic cardiomyopathy is exactly what we're talking about. And once we know exactly what we're talking about, I think the definition, it's going to then help to try and investigate it. Because at the moment, I think we have lots and lots of studies in this sphere, some of it which can be a little confusing. And probably my own research will fall into that category because I think we're not always completely certain about what it is that we're talking about. And I think once we've nutted that down a little bit, we are going to be able to find out more about this entity. So I'm going to start with the idea that obviously there's septic shock. Shock is where we've got an inadequacy between supply versus demand. And the classic way we're described to think about septic shock is a distributive form of shock. And if you have a purely distributive kind of shock, I think the heart can respond in a different manner, such as someone with anaphylaxis is going to have a distributive shock, but their heart might not be affected, as opposed to someone with septic shock who might have a cardiogenic component to it. So it's almost like we have two types of shock that are occurring at the same time. And the way I'm going to try and separate that in my head is I'm going to show you an example of each of them, because the first type of septic shock is not a septic cardiomyopathy. It is absolutely there. Both of these categories are people who are in septic shock, but only one of them has a septic cardiomyopathy. And by definition, that's someone who's got a cardiac abnormality which has occurred. And the tricky thing about that is that sometimes we don't know it's an abnormality because we don't know what the heart was like beforehand. And maybe I'll get into that in just a second. But I'll start with the first bit. So that the first one is like an example of a guy we had in the unit who got presented at one of our meetings recently, who was a young gentleman with necrotizing pancreatitis, with an acute kidney injury that required some dialysis. He had mild inotrope requirements. And then overnight, when people came on in the morning ward round, he had this rapid escalation in his inotropic requirements. They felt that he was vasodilated, and there was a concern that there was some form of infection that had occurred. So there was some form of infected necrotizing pancreatitis, I guess, was one of the ideas. And with this rapid escalation, though, they wanted to have a look at the heart. And so this was the echo image that was given to us. So, and I'm saying right at the beginning, this is the kind of heart that I am describing, I do not think fits into the category of a septic cardiomyopathy. But it's really important. And so we're just going to start with this because I think there are some really good learning points that I thought came up when I was reporting this echo. And in particular about how to talk about hearts like this in an exam. So Hatim, you're doing the exam this year. Are you happy to start off with this? So I've given you the story of a 45-year-old guy rapidly escalating inotropic requirements. Can you comment on this echo image for me, please?
So this person has lung axis with a little bit of lung just shown behind the heart. And it's showing hyperdynamic systolic left ventricular function with thickened left ventricular walls, both septal and posterior walls or infralateral walls, and more likely representing concentric left ventricular hypertrophy. Chamber size looks, from the left ventricular point of view, looks a little bit on the low side, with end diastolic diameter more likely will be small. It's not particularly foreshortened, but I would like to confirm this from a different view. Aortic valve and mitral valves looks functioning well, but I would like to visualize them with color Dopplers. Left atrial size looks within reason, and right ventricular outflow tract again looks within reasonable size, and the right ventricular function looks seemingly as well okay. So I would like to confirm it again from a different view.
Really nice. So some great things in there is talking about, I think the cadence, the speed at which you're talking is perfect. Getting to the good stuff, the big stuff, the meaty stuff early on, that's absolutely fantastic. And the last thing is to say, with all of the findings, that you want to back them up in other views is great. And I think that the length of time you're talking in total is also good. That was probably about 45 seconds. And maybe just as a note for everyone, when you're discussing these things for the exams, it's important to stop talking, right? So if you're going to talk about an echo image, give yourself 30 seconds, Keep it short, sweet, efficient, stop talking, and that has a double effect. The first of all, it means that you're going to get through the questions a bit faster because there will be 6 questions in 40 minutes. You have to complete all of them. So the examiner will speed you up if they need to, but also makes you sound smarter. So, to start, have a beginning, a middle, and an end, a systematic approach. It gives that view of.
And the last thing, this running is sinus tachycardia top to 140.
Nice, here we go, very good. So and just in terms of the feedback, excellent. Don't forget the sinus tachycardia. I told you this guy was sick. He'd got vasodilation. You missed out the sinus tachycardia. Second thing is about hypertrophy when you've got a potentially underfilled. So I think this is a small ventricle. We've maybe even got the signs of a kissing ventricle sign. You're going to get pseudo hypertrophy, we call it, which means that when you don't have a lot of blood in the heart, the if you like, the connective tissue and the collagen and everything means that the heart can look thickened. So you cannot call hypertrophy in a potentially underfilled hyperdynamic heart. So a way you might say that is the thickened walls that we can see here may be related to the small left ventricle dimensions, which may suggest hypovolemia with the kissing ventricle sign, the hyperactive hyperdynamic sign. If I'm worried about hypertrophy, I've simply got to look at old echoes or look at the one after this gentleman has hopefully recovered. The next thing that grates me, as I'm sure the audience is going to have me say many times, you said it's a little bit on the low side. He said it was a little bit on the low side.
Small left ventricular industrial diameter.
He said, yeah, the left ventricle is a little bit on the low side. It's a small left ventricle end diastolic diameter. It's the appearance of hypovolemia. Say what you want. Don't tell me it's a little bit hypokinetic. Don't tell me it's mild to moderate. Make a call, and that just efficient communication. And yeah, that's good. Fantastic. All right. So you wanted other views. There you go. What do you think of this?
So this short axis at the mid-papillary muscle view, and this confirming the same findings. So with hyperdynamic left ventricular function and small left ventricular end diastolic diameter, all consistent with signs of hypovolemia, no pericardial effusion, and the interventricular septum is contracting in. Sorry, I take it back. So, yep.
Yeah, no,
and still tachycardic at heart rate of 136.
Fantastic. Yeah, the terminology I love to hear in this one is also obliteration of the end systolic cavity. That whole thing goes down. It's like the fist going completely to zero. Again, indicative of hypovolemia, possibly. Again, I think clinical correlation, you've got to say, is in there, that wonderful statement. All right, now we'll get to the good stuff. What do you think about this?
So that's a focus view over the left ventricle from an apical view. Likely, I think it's an apical 2-chamber view. I can confirm nearly the same findings, although here that I think the left ventricle looks dilated from that view.
No, maybe it's just the way it's coming out. It's again, it absolutely confirms all the other findings. Imagine it's the 4-chamber view for me, just because it helps the next bit. What next views would you like to look for if this was the 4-chamber view? Where are you going to go to next?
I'd like to get an apical 5-chamber view.
Yeah.
So I'd be able to obtain a pulse wave Doppler across and identify whether there are any signs of mid-cavity obstruction.
With pulsed wave Doppler?
Sorry, with continuous wave Doppler.
Yeah, nice, but I think it's a bit of both. It's not unreasonable because that's exactly where we're going. So with the pulsed wave Doppler, we can try and get an idea of cardiac output, which can tell us if we are hyperdynamic with a high cardiac output because of the tachycardia. We've got a LVOT VTI of 21, which is normal. But again, in a hypovolemic or a hypovolemic state, that 21 can almost be considered a raised stroke volume, if you like, particularly the tachycardia, giving you a very high cardiac output. And so that would be the first thing I think to look for, is to try and have an estimate of what that is. And then the second thing is also to have a look down here in the bottom thing. What are we seeing here? So you said you were looking for some form of obstruction. Are we seeing it down here?
So, yep. So that's continuous wave Doppler across the aortic valve and the left ventricular outflow tract, and that's confirming that there is a pattern of obstruction, more likely mid-cavity obstruction, with going, I described usually as dagger shape.
Really nice, Hatem, really nice. And I think that's where the pulse wave can come in, to, particularly if you're around here, you can see it's around 1, if you can see it under there. That pattern in there. It's quite a subtle sign. And as you say, it can be a form of mid-ventricle or apical or some lower ventricle obstruction. So it's often not LVOT. It can be, of course, but it's lower, and that's a sign of hypovolemia as well. And there's a really nice paper, and I'm sorry, I should have put it in here. It was done by Michelle Slama's group, and the main author was Julien Maisel. And Julien Maisel and Michelle Slama, they arranged a multi-center study. I think it was something like 250 people across 4 different centers, and they looked for exactly this. And they found out that this and lactate were both associated with people in septic shock with signs of increased mortality. And what I read by that is if you're hypovolemic, that is bad. And you can pick up that hypovolemia clinically, of course, but you can also pick it up with echo. So hypovolemia is bad, hypervolemia is bad. So it's the Goldilocks principle, as Ian Seppel would say, and you need to find just the right amount. And so this would be this echo. I think I reported it as saying, there are echo features suggestive of hypovolemia, and that is seen because of the small left ventricle dimensions, the hyperdynamic systolic function, the raised cardiac output, the kissing ventricle sign with signs of mid-ventricular obstruction. All of those point towards hypovolemia. Clinical correlation required, of course, no significant valvular abnormalities.
And should I seek evidence of dynamic left ventricular outflow tract obstruction or systemic anterior motion?
Absolutely, and that's where the pulse wave Doppler comes in that I thought you were alluding to at the beginning, which is then you can step that pulse wave Doppler through that ventricle to try and find out where the site of the obstruction is, okay? But even something as subtle as that, I think, points towards hypovolemia. Now, I'm probably doing this lecture wrong because this is not septic cardiomyopathy, but I thought it was a really good one to report, and it's a really good one for the exams, because I think there's a lot of stuff in there, and if someone's giving you that hyperdynamic ventricle with a story of septic shock, this is what the examiners are going to expect you. This is what we should be thinking of in the clinical context if you're doing advanced echo, of how we can use Doppler to try and look at signs of hypovolemia. You'll notice I'm not really including the IVC in there. There can be lots of confounders to that, particularly mechanical ventilation, TR, pulmonary hypertension, blah, blah, blah. These are the more sort of solid findings that I think I look for on an everyday basis for someone who's got hyperdynamic septic shock with a hyperdynamic systolic function, okay?
Sam, how many of these findings would you see just if someone's on a heap of NORAD?
Yeah, great question. I mean, again, I'm not 100% certain I know the answer to that question. I don't have a lot of evidence to back this up because, as I say, I think the evidence is a bit dodgy sometimes because these are the kind of patients that would be included in a study of septic shock, including some of my own earlier research, which I don't think's right. If we're talking about septic cardiomyopathies, it's a different beast. If I put you on 40 mils of NORAD and I push your blood pressure up, I think your heart would look like this. And again, I think it's important to say clinical correlations required because, I guess it's this idea about being fluid responsive. Do I need to increase your cardiac output by giving you fluids? I think it'd be a normal feature, right, to probably get those kind of signs if I put a normal person on lots of NORAD.
Yeah.
Well, the question for me, though, is if you're on lots of NORAD and your lactate's up, these are the kind of people I'd be giving fluids to. And you give it in small amounts. And if the right heart's dilated, I still think you've got to give fluid if the heart looks like this and just go slowly, right? Right, so septic cardiomyopathy. So this is the second piece. So if you've got septic shock and you've got direct myocardial depression, that's when we start to get into the septic cardiomyopathy sphere. And I think it's really clear that we need to be certain of what that is. And this is the criteria that I think should be included for people in studies. Now, I'm not entirely sure I've seen a study that has done this yet, and I've done a few of them, and I'll be the first to put my hand up and say I think I did them wrong. So I think if I was going to do another study into septic cardiomyopathy, this is what we should be saying. The septic cardiomyopathy, by definition, is acute myocardial depression. And that means one of the things I'll say is if I see a dodgy heart in someone who doesn't sound like they've got a lot of features of heart failure in the past, you've got to say, I want to look at old hearts, right? I want to know what previous echoes look like. If I don't have it, I've got to look at future ones, all right? So the main point of it is that it's acute myocardial depression. It's reversible if you get rid of the infection. It's not going to give you it's what I say, it's not going to give you regional wall. It might give you regional wall, but it's not related to blockage of a major coronary artery. So it's unrelated to a type 1 myocardial infarction. That can be a little tricky to tell, right? Because I'll get to this at the end of the talk, is I don't quite know where septic cardiomyopathy fits in with stress-induced cardiomyopathies and reversible cardiomyopathies as a whole. So I'll just give you my thoughts at the end of this, which is, again, something else I think we need to look into. So all I can say there for certain is that it's not related to a big blood vessel being blocked off with a thrombus. It's going to affect both your left ventricle and your right ventricle. That's not universal. It can affect both systole and diastole. Systolic, obviously, is much easier to look at. Diastole, I'm still not really certain how to affect it, but I'll use the guidelines as best I can. And it can cause a dilation of a left ventricle. Now, the dodgy evidence that we have to date, and as I said, that includes a lot of those first group of patients we just presented. And so again, I think we've got to take it with a bit of pinch of salt, but the best evidence we got today, and the big meta-analysis such as done by Prof. McLean and Stephen Huang, would say that the worst prognostic factors are a dilated, badly functioning right ventricle and a dilated left ventricle. There's other evidence that suggests it's also related to maybe diastolic dysfunction. But if you think septic cardiomyopathy is defined badly in the literature done by critical care doctors, you ain't seen nothing yet till you've read the diastolic literature, which is equally all over the shop. So I think these are the two areas I particularly think that we need to, as a group, just tighten up. So this is the definition for me of what septic cardiomyopathy is. And if anyone's thinking of doing a study, it needs to be related to these factors, in my opinion. So it's pretty common, right? So let's just take, this is a friend of mine, Juan Pulido, who's met over in the States. So he did this study that's quoted all the time, and it's in like 105 patients who are across 4 different ICUs at the Mayo Clinic. And he got patients who were in the, this was done, I think, before the new guidelines. So it was in patients who were defined as severe sepsis or septic shock. So it's basically patients with a good definition of infection who were on inotropes or had raised lactates despite fluid therapy or had some form of acute organ dysfunction. And he found that there was myocardial dysfunction. That's what I like about this study, is it just clearly defines these guys who had dysfunction of their LV, systolic or diastolic, or RV. So this really nice diagram shows that idea that it's myocardial depression, which makes up, he just calls it myocardial dysfunction. And these are the guys that I think need to be analyzed for septic cardiomyopathy. What we don't know is how many of these guys had long-standing dysfunction of any of these things in there. And that's what is also unclear. But taking that out of the picture for the moment, you can see that it's in about, say, 60% of people who come in with sepsis on inotropes with some kind of organ failure have myocardial depression. Of that 60%, about half of them have some form of LV dysfunction, or maybe 2/3 have some form of LV dysfunction, and about 1/3 have just systolic LV dysfunction or systolic RV dysfunction. Okay, so it's pretty common, as I'm sure all of us are aware. So let's just have some examples of that. So this is a 49-year-old guy who came through into our unit a few years ago, and just in the meaning of time, I'll flick through this because you're probably all going to know what I'm talking about. So we got in this parasternal long axis view, we're seeing a guy who's got what looks to me a dilated left ventricle. So I'll use the markers down here. I'll take 6 centimeters being dilated. I think that might be getting up to it. So he's got a dilated left ventricle. It looks like there is severely abnormal dysfunction, and I'll call it global hypokinesis. So no obvious regional wall motion abnormality in coronary artery distributions. But going with that idea of the RVOT should be the same size as the ascending aorta, that should be the same size as the LA, it doesn't look completely normal, right? And so one of the things I'm going to say when I look at this, particularly when we've got a left atrium that's dilated, and I know it probably takes a couple of days for that to grow up, and the RV is dilated, is there a chronic component to this? So this would be the kind of guys I'm not sure. Someone just asked you, should acute dilation be part of the defining criteria? No, I don't think it should be part of defining criteria, because I think you can have acute myocardial depression from sepsis, particularly for diastolic or systolic, and have a normal sized ventricle. But I know that if you do have LV diastolic dysfunction, that's a worse criteria based on some of the meta-analysis. So I don't think any of these things can be a defining criteria, but you've just got to assume, I think a defining criteria should be that it's acute. Maybe that's the only defining criteria. And there should be some form of myocardial dysfunction. So looking at this, I don't know if there's a chronic component to this or not. So what you'd be saying in my report, this has features of a septic cardiomyopathy, but there are features here that suggest there may be an underlying chronic component to it. Follow-up echo is recommended once the patient is hopefully recovered. Okay. Other views are needed. Here we go. And I'm showing you down here in the bottom right, the post-recovery ones. And so we can see that there's definitely an improvement in there. What we're also seeing is this pericardial effusion that's in there, maybe a dilated right ventricle with a bit of a septal bounce. I don't think there's any major interventricular conduction delays. That suggests that maybe the right ventricle is coming into this. So maybe we've got, maybe there's a, biventricular effect of this infection. And maybe it's something that's been grumbling along even for a few days, weeks. I don't know, meningococcal septicemia, that kind of happens pretty acutely though, doesn't it? So these are the kind of thoughts that are going through my head as I'm looking at this guy. And I think the same thought should be going through researchers' heads if they want to investigate it. Have a look at other views. This helps show the global pattern. I think this right ventricle is probably mildly impaired. Left ventricle is more severely impaired. But again, this big left atrium makes me wonder whether there's a chronic component to it. But if we compare it with the one afterwards, that suggests that this all was an acute phenomenon. Everyone with me so far? All right. Repeat myself, it's not just the left ventricle, of course. The right ventricle can also be affected. So here we've got a 51-year-old female, septic shock, ARDS. Day 2, she's becoming increasingly hypotensive, and she's on noradrenaline, and we've added in milrinone. We can notice the blood pressure is not great. The saturations are maybe a bit low for someone who's on 40% oxygen, but we got peak pressures of 27, and I think the PEEP is in there at 10 or something. Yeah, the PEEP at 10. So we've 6 mils per kilogram ideal body weight, 17 centimeters of water. It's a pretty high driving pressure for 450 mil tidal volumes. Okay. We've got patchy changes, particularly in the bottom 2 quadrants. Probably could persuade myself there are 4 quadrant infiltrates. We need to make sure the left heart's not playing a massive role in this, and is the right heart okay? Louise, do you want to go at this? What do we think of this? So high driving pressures, 6 mils per kilogram ideal body weight. What do you think of this picture? So we've got 4 quadrant infiltrates on an ARDS picture.
Okay, so the most obvious abnormality is flattening of the septum.
Yeah.
But my eyes aren't quick enough to catch whether it's systolic or diastolic. If it was because I'd need to slow down. If it was just diastolic, then I'd assume it was volume overload. The right ventricle looks a bit enlarged. There is a suggestion that there might actually be a pericardial effusion. We would need more views.
Nice. Keep talking to me about the right ventricle. So you said you thought the right ventricle was enlarged. Mild, moderate, severe?
Wouldn't say on this view. I'd need an apical view.
Okay.
But I'm not sure. So this bit here.
Nice.
I'm not sure what that is. Is that the wall of the right ventricle?
No, it's not.
In which case, has they got a pacing wire?
Nope.
So there's an echogenic mass that's flicking around in the right ventricle. So that's why I wasn't sure whether
and it looks like it's a septum to the free wall and it's connected to this septum. So what could that be? Because it's big and echogenic.
Well, it could be a thrombus, but it's a bit too echogenic to be a thrombus.
Moves with the wall?
Moves with the wall. Oh,
yeah.
Just had a mental blank. The moderator.
Moderator band, beautiful.
Yeah.
So that's all the nerve fibers are sitting in there. And I also think we got a bit of trabeculation that's happening up here. So I think this is a pretty definitive moderator band. I can't really see the free wall very well, but it looks like it potentially might be thickened. I think if we're seeing trabeculations in that moderator free band, again, the thought's going to be, is this chronic? Yeah, nice.
Or is it acute on
Beautiful. And absolutely, we can get acute on chronic. So again, there can be acute components to deterioration, and that might fit into that idea of a septic cardiomyopathy. And in terms of two suggestions, the first I had, if you're trying to look for the bounce, and I'm with you, I find it tricky, don't look at the actual septum, put your eye in the middle of the ventricle. And what you're looking then is you're trying to pick up with the outside, your peripheral vision, you're trying to see when that free wall comes in, and if you see that bounce coming in with that then, and that's during doing systole. So I think this is during systole.
Yeah.
Beautiful. So that's a pressure overloaded right ventricle. That is a ventricle that I would then consider to be at risk. And that means that someone who's got a driving pressure of 17, this will be the type of person I'll be saying, okay, we need to watch the CO2, we need to watch the oxygen levels, try and avoiding hypercarbia, hypoxia, anything increasing the pulmonary vascular resistance. And we need to think about the PEEP, and we need to think about the driving pressures.
So, but if you think the right ventricle's enlarged on that picture, then they've got volume overload as well.
Yeah, absolutely.
So
and
it's kind of a bit artificial.
Yeah, and maybe we need to diurese them. And again, I think it's a balancing act, right? In terms of the RV size, I think you can do it on these. This is my backup view. Again, I just look at the difference between the black bit there and the black bit there, and just look at the areas. And I think this is a moderately enlarged right ventricle. But I agree, apical four chambers would be better, wouldn't it? But sometimes the apical four chambers are a bit rubbish, like this one.
Oh, well, you can see the septum comes up the middle, so yeah, I'll go on moderately enlarged.
So, why would you call it septum cardiomyopathy and the sequelae of ARDS? So the question comes in is, why would we call this septic cardiomyopathy rather than sequelae of ARDS? Again, great question. And I think it's a septic cardiomyopathy because it's that until proven otherwise. I think it could be a bit of both. Again, I guess I'm trying to use these cases as the difficulty that we can face, because these are absolutely the cases that are going to be included into the research that you read on septic cardiomyopathy. And I think it is sometimes more difficult than that. Again, maybe for exam purposes, it's, the definition is obviously that it's acute myocardial reversibility. And as the question goes, maybe this is just related to the ARDS. And the way we're going to figure that out is to start playing around with the ventilator and see if we can make it better. And I guess if you play around with the ventilator and it gets better, then it's ARDS and maybe not septic cardiomyopathy. All right. Right, the next bit, then it starts getting really complicated. All right, so how do you tell diastolic dysfunction in the critically ill? I think we've just got to use the guidelines. I think if we're going to try I'll use this as an example of someone who I consider to have diastolic dysfunction because we've got an E to A ratio that's greater than 2, and they've got someone who had a reduced systolic function with an E to A greater than 2. That is, by definition to the guidelines, someone who's got significant, do we say severe myocardial dysfunction, diastolic dysfunction. The big thing for me, or I think the literature that I think is the most robust, done in animal studies, again done by the European guys, says particularly what we should be really looking at is the TDI. So if we're looking at the tissue Doppler, looking at the E primes, and if those are less than on the medial, if they're less than, let's say, 8, and on the lateral, if they're less than 10 centimeters per second, then that would be a sign of significant myocardial relaxation impairment. So, as I say, I'm going to look at systolic function first of all. If the systolic function is down, by definition, they have diastolic. If the E to A is greater than 2, it's severe. If it's less than 2 but greater than 1, I'll look at the tissue Doppler and I'll have a look to make sure that the TDI is less than 8 in the medial and 10 in the lateral, and then I'll be describing them as having diastolic dysfunction. Can it be acute? You bet your ass it can be. So we did, in some of the dodgy research I was talking about in my own that I've done in this, we saw loads and loads of people who kind of met that criteria for diastolic dysfunction but had a normal sized left atrium. And of course you expect people with raised left ventricle end diastolic pressure to have dilated left atriums. And when we followed these guys up from day 1 to day 3, we found a significant portion of those that we labeled as having diastolic dysfunction by these criteria on day 1. By day 3, a lot of those guys then had left atrial dilation. So I think it takes a couple of days for the left atrium to dilate up.
Sam, how many of those did you follow out to month 1, month 2, month 3, and see how much of those?
Big fat 0. I was quite impressed. I did day 1 and day 3 personally. It's and it was like in 100 patients or something. So it wasn't too bad. I think it'd be fascinating to try and do that. That's exactly what we need to have a look into, I think, and maybe this is where ICU follow-up clinics come in.
Because you're playing around with definitions that are not universal, like there's no standard definition of septic cardiomyopathy. You're applying guidelines that are not written for people that are critically ill, and there's no long-term follow-up on any of these people. Like it's just throwing darts at a dartboard blind, isn't it? No offense to the specialist.
Sums up my career so far, yeah, absolutely right.
No, Ben, I think you're overstating the case. I think you might have one eye patch on, but that's it.
Yeah, we got one eye patch on and a moving board. I think you put that very nicely. I think we are at the infancy of our understanding of how critical illness affects the heart. I think we need robust research, which is where I'm getting to, and that involves, which is why we're doing this, right? I think you've got to be really bloody good at doing standard echoes before you can start imaging the critically ill. And we've got to understand where the holes in what we're talking about are, and the holes are massive. And once we've figured out where the holes are, then we can start plugging them by trying to be scientific about it. And for me, that's what these Friday afternoon sessions are all about. We just got to make sure that we are speaking the same language. We understand where the concepts, the holes are, and we need to have people talking about this as a problem. So I completely agree, and that's why we're here, I think.
Yep.
All right. So listen, of course, there are these other cardiac abnormalities that we're going to see in shock. And I am not sure where these fit into this picture. But I think if we are going to move forward, we've got to say that these probably, some of them aren't septic cardiomyopathies. So the first one is regional wall motion abnormalities. And I'll show you an example in a moment. And with septic cardiomyopathies, we can get a whole bunch of regional wall abnormalities that we know are not related to type 1 myocardial infarctions, because we see troponin abnormalities like all the time, right? We can get troponin abnormalities up into the several thousands of people with septic cardiomyopathy. We send them off for caths and we see that their coronaries are completely normal. Now, those guys still could be called having a septic cardiomyopathy or a reversible cardiomyopathy or whatever you want to call it. I think these hyperdynamic contractions are not septic cardiomyopathies because that is a normal response to vasodilation. The fact that these guys, there's evidence to say that people with this kind of pattern might actually have a worse prognosis, I still can't quite get my head around. Because for me, it makes sense that if you've got a hyperdynamic ventricle, that's a normal response to sticking someone on catecholamines who's vasodilated. So again, I'm not quite sure about that. We can also talk about people who either have interventricular obstruction or they've got some form of LVOT obstruction because they become a little bit hypovolemic with a sigmoid-shaped septum and they get that LVOT blocking off their outflow. Again, I don't think these guys are septic cardiomyopathy, but it's certainly a cardiac abnormality, and I do not think they should be included in studies. Another very common cardiac abnormality you'd see, which I don't think would fall into the category, but we should be aware of that it comes a lot in sepsis, is fluid overload. So that would be someone with big left atriums, with interatrial septum pushed over to the right maybe, or big left ventricles, big dilated IVCs that don't have TR or don't have huge high driving pressures, lots of B lines in the lungs. Those are the guys that we should look at, and diastolic dysfunction, stuff like that. So, summary, septic cardiomyopathy is acute, and that means we've got to look at old echoes, or we've got to do repeat echoes once they got better. It's reversible because it's going to get better with time. It's not related to any major coronary artery occlusion. It can affect both your systolic and your diastolic function of both your left and your right ventricle. It can be associated with a dilated left ventricle, which has been suggested to be associated with a bad outcome. So they're ready. So where does this fit in? Okay, so we had a 65-year-old lady. She had pneumonia, bacterial superinfection on top of that. She's got pretty mucky looking lungs, maybe collapse of that right basal portion. And she's on a not insignificant amount of, can't say that. She's on a significant amount of catecholamines. Anne-Marie, do you want to give us your thoughts on this?
So the top left one's an apical 4-chamber view, which shows overall. Can't really comment on the size of the left ventricle on this view, but I think it might be dilated. I'd have to check in another view.
Yeah.
The overall systolic function is impaired. It looks segmental. There's better contractility at the bases than the apex. So I'd be thinking along the lines of Takotsubo or an LAD lesion. Again, I'd want to see more of the segments in the short axis to confirm.
Yeah, beautiful. We might talk about the left atrium being dilated, bowed over to the right, so suggesting raised left atrial pressure. Yeah, very nice. And there's this hinge point here, which I think is often seen. And the walls they don't look super thinned compared to the ones that aren't, suggesting it might be acute. Those are the kind of things to look at, right? And absolutely, this was a Takotsubo. This is someone we sent off to have a cath and they had normal coronaries. So do these guys fit into the pattern? You know, I think maybe septic cardiomyopathy, Takotsubo, these weird regional wall motion abnormalities that we sometimes see in patients who are on catecholamines, that often that dysynchrony that we see in a septic cardiomyopathy sometimes, particularly when we're using spectral tracking to have a look at them, all of these might be fitting into these regional wall motion abnormalities, but the important thing is they're not related to a type 1 myocardial infarction. And I think maybe these are all under the same umbrella of reversible cardiomyopathies. But should this be included as a septic cardiomyopathy? Again, I don't really know the answer to that question. And so I think it's really hard. But yeah, I think there's potential that some of these have a similar kind of etiology. And again, I think we need to look into that. So I guess that's the lecture. Maybe before we go on to the case I wanted to present, is there anything that anyone would like to ask or add to that?
Sam, so we talk a lot about that sort of at-risk RV, and we know things that we can do in terms of optimizing the RV afterload, preload, and contractility and things. I think there's less sort of out there in terms of what we can do for the, I don't know, maybe I like the LV in terms of if we do think it's a septic cardiomyopathy for the LV. I know there's some studies again looking at levocemendin and things. Do you know of any other sort of treatments that we can give, or any, like, is, you know, how would you approach that at-risk sick left ventricle apart from treating the underlying cause and not trying to drive them too hard with catecholamines? Is there anything else that you know, other magic potions, I guess, trying to improve vascular resistance with steroids and what have you, but is there anything else that's sort of out there that's emerging, or
not that I'm aware of. I think we've got a relatively limited number of tools to play with in this field in the non-mechanical support area. You know, what have we got? I think route number one has to be is obviously sticking people on NORAD. I think if the NORAD goes up into the mid-teens, you need to get the echo out and have a look to see if the LV is impaired. Obviously, we're treating the underlying cause, just giving source control before I go any further. Try not to fluid overload them if they've got a bad LV. And then what have we got? Well, then I think if you've got a bad LV, you've got to look for something that's going to kick the heart more than squeeze, right? So I don't think we should be reaching straight away for the vasopressin. I think we've got the other choices are dobutamine. I think if you're okay that you don't think you're going to get an arrhythmia, I think probably reach for that first because I'm most familiar with it. You've got levocemendin, you've got adrenaline. You know, I don't think we've got an enormous number of things, and you just got to go physiologically, don't you? There's no magic treatment in there. I know that the sepsis data suggests that if you're getting onto dual catecholamines, that's when you should be adding in the steroids, and you're not adding in the steroids to try and improve their mortality. You're adding them in to try and reduce their catecholamines. And the reason why you want to reduce their catecholamines is we've got this fascination with trying to aim for a mean arterial pressure of 65. And sometimes I wonder when we're starting to, you know, squeeze the microvasculature even more, we're actually probably not improving oxygen delivery. We're actually could be even making it worse. So to be honest, I don't know the answer to your question. I think you probably answered it answered it already. There are no studies that are looking into this. This is what we need to do next, in my opinion. We need to have a trial that looks into how we practice medicine, in my opinion, which is we stick people on NORAD. Most people who are on single strength NORAD are kind of going to get better, right? But when you're starting to get up in the mid-teens, that should be the inclusion criteria for a bunch of people who know what they're doing to go and have a look at the heart. And if the heart has a reduced ejection fraction, that's the inclusion criteria. And then you say, right, well, if they don't have any contraindications, stick them on dobutamine, let's see what happens. Or we stick them on adrenaline. Or we think about levosimendan. That's, yeah. I don't know, that's how I practice medicine, right? But I don't think I've ever seen a study where it's done that.
I think, Sam, it's a little bit tricky in this situation, but definitely with the involvement of the right ventricle, and as you exactly mentioned, the at-risk right ventricle, increasing the doses of noradrenaline, any dose that would be in double digits, would definitely have further impairment because of the vasoconstriction, and that would be increasing the preload, cardiac preload, both for the right and ventricles. And as well, it would cause pulmonary artery vasoconstriction, which would be more compromised for the right ventricular function. So as soon as this would be the case, I think definitely the first consideration is to add the catecholamine sparing agent, at least vasopressin to start with. Further addition of inotropic support, I think, would be guarded. But the only evidence that came so far is from some few studies that compared levosimendan compared to dobutamine, and definitely it would have better lucitropic function. It would have better inotropic function without increasing myocardial oxygen demand.
Yeah, but did they look into it? But did they look in the right group, like the leopard study, which is
not the leopards? There is another study that came from China in, I think, 2016.
And they used echo, right? They actually did it in people who had bad LVs.
Yeah,
nice.
The only caveat here that it didn't change the 28-day mortality, but it definitely had marked improvement in the right ventricular function and in the systemic hemodynamics and the dose of vasopressors as well.
Yeah.
So I think the earlier consideration.
I forgot to mention milrinone as well in the last.
Yeah, and milrinone. Although again, there is one study that compared milrinone to dobutamine in that context and didn't make any difference. Didn't show any difference.
Yeah, nice comments. We've got a couple more minutes. Should we just quickly go through this echo? Who else is doing their DDU this year? Anne-Marie, are you happy to go through this? I think you probably know this study pretty well. This is a 85-year-old lady. Excuse me, it's an 85-year-old man who has urosepsis, escalating inotropic requirements. And this was done to try and determine if there was a cardiac component to it. So why don't we start with... Go for this one, Emery.
Okay, so parasternal long axis view. The LV doesn't look particularly dilated. The atrium doesn't look dilated. The right ventricle doesn't look dilated. The function looks reduced. I'm not entirely sure how reduced at the moment. I'd like to see more views, but it doesn't look normal. Sort of some E-point septal separations, long. The mitral valve leaflets are thin and mobile, but again, they don't open widely because of the impaired function. Aortic valve leaflet is thin and mobile. RV looks normal size, but also looks like there might be some impaired RV function on this view.
Cool. So take me to that next step. So I gave you that, we got that stem of the urosepsis. Just give me a little bit more, because the examiner will want to tease us out of you. You said you've got normal LA size. Do you think that's unusual given this? Maybe that might be the problem.
Well, the function's down, so normally you'd expect the atrium to be dilated.
Fantastic.
In impaired function if it was chronic.
Yeah, nice.
But not if it's acute.
So what do you think might be going on?
So it could be an acute septic.
Oh, yeah, it's amazing. Yeah, it was great. Fantastic. So that would be in the exam, if you can take the examiner to that state, and obviously we'll have a prompt in there, something like along those lines, right? And just, the good candidate will take us straight there, give that beautiful presentation again, nice cadence, nice short structure, but they'd say that left atrium size is small is a bit weird. I want to have a look in other views, because if it's small, that could be acute. And if it's acute and he's got urosepsis, it could be a septic cardiomyopathy. I want to have a look at old echoes to try and have a look to see if it's acute or chronic. If it is chronic, he may be underfilled, something like that. So other views, let's have a look at blah, blah, blah.
Okay, is that the one you're on?
Yep.
Yep, peristernal short axis. It's off axis, it's slightly between mid-pap and mitral valve. There's some caudal leaflets in there. Again, the septum looks D-shaped. Is the striking abnormality, and the function still looks impaired. I'd go probably, I want to say mild to moderate.
But you're not going to. That's excellent, excellent.
I'll say 35 to 40% as ejection fraction. Let's put it on that. I have to move that because I can't see the numbers. Sorry, Louise.
Okay, so we've got a medial septal, a medial E prime, which is 5. We've got a lateral, which is 6. We've got an E to A ratio that's just less than 1, and we've got a normal left atrial size.
Is it
no significant, nice, and there's no significant TR that we can elicit on this.
That kind of puts me under none of those pathways because there's tissue Doppler's impaired. The normal LA and the absence of TR make me think it was going to be pseudo-normal or moderate.
And I think if you've got a reduced, moderately impaired systolic function with the reduced TDI, this would be that group that I would say would have, and again, we could argue, they have some form of diastolic dysfunction because those E primes are so bad. And because their systolic function, by definition, you have diastolic dysfunction that's supported by the TDI. The left atrial size, don't worry about it because it's probably acute. I would label this guy had moderate diastolic dysfunction. And I'm sure that lots of us would probably argue other ways, but that's how I do it that's my logic. It would be indeterminate. Yeah, so there's a comment here, so it'll be determined as part of the guidelines. My argument against that would be that in the guidelines, you've got section A and section B. And in section B, it says if you have a normal ejection fraction, you automatically go into section B. And the lowest part of that flow diagram is mild diastolic dysfunction. And so with the impaired systolic function, you're automatically in group B, which automatically means you've got diastolic dysfunction. And then I go on the E to E prime.
Yeah, it would be still one criteria out of 3, which would be indeterminate.
Yeah, but you can't look at the left atrial appendage because it's acute diastolic dysfunction. Sorry, you can't look at the left atrial volume because it's acute. So you're left on only 2 of them. Yeah, and yeah, good call. So maybe I'd say they just got diastolic dysfunction.
Would you say mild to moderate?
No, I would not say mild to moderate.
Sorry.
So the defining criteria should be having wave velocity less than 0.5.
Yeah.
You would be able to.
Great comment, Hatton. Great comment. Yeah. I think that's sort of everything, really. We've run out of time. I don't think there's much more to say on this one. So I guess if in these kind of cases, just take the examiner to that next stage. And if I'm saying they've got horrible sepsis there, and they're on lots of catecholamias, and they've got this kind of pattern, you've got to think septic cardiomyopathy. That's going to be the buzzword. Do they have this acute, reversible LV and RV? Look at the LV size. Is there diastolic dysfunction in there? Those are the kind of questions that we've got to be asking. And how do you know it's acute? Well, I'm going to look at old echoes, and I'm going to do follow-up echoes as well, and go from there. All right, well, I think we've run out of time a little bit. Okay, any final comments, questions from anyone?
That was great, Sam, thank you. I'm so confused now, though. Like you say, there's nothing really out there to drive or we need to, as a group, as you were saying, get better and try to do more research on these guys, and then ultimately take it to what we can do. People talk about acute renal success and all of that. So I think I read in one of your papers about cardiac hibernation, and it's actually, maybe acute heart success that it's trying to hide away and not do so much work. And perhaps what our job is to not cause further damage, and that's the important thing, getting our treatment right, rather than trying to get it to be normal, just accepting it, it's not normal, but trying to minimize further harm to that at-risk right or left ventricle.
Yeah, I completely agree. It's just I'm not entirely certain sometimes how to do that. But maybe it's like lowering the blood pressure targets. I always love those papers where they looked into that one. You've got to individualize patient therapy, I guess. And if you're doing something and something's getting worse, you've got to ask if you should have done it in the first place, right? And don't overload them.
Role of speckle tracking, Sam.
Beg your pardon?
Role of speckle tracking of strain.
So speckle tracking, and we'll do another lecture on this, but speckle tracking is a really good way of picking up myocardial dysfunction. I think it's really, really hard. You need beautiful pictures to be able to do it, and you can get really weird numbers if you don't know what you're doing. So I think there's a potential at this stage that with the enthusiasm for new technology, we can jump into it a bit soon. Having done my PhD on this, I should be careful what I'm saying, but I'm still not certain it's ready for everyday use. But if you want to publish data, it's a really nice thing to add in. I think it's worth looking into. Short answer to your question, it's worth looking into, but I think there are more conventional methods that we need to make more robust, have a more robust idea on first. And if you're going to use it, maybe the best thing is the right ventricle.
Sam, do you know if there's any data or do you know much about the data that's come out of the COVID patients overseas? Because obviously there's a cohort of COVID patients who went down with acute cardiac issues, the younger ones. And they're talking about long COVID survivor clinics now, and they're setting those up in the US and the UK. Do you know anything regarding echo findings in that?
The first one that I'm sure this group is not going to be surprised about is that in the acute setting, there are a bunch of people with bad right hearts. The right heart is smashed in this cohort. And that is more so than I guess what has been seen maybe with ARDS. And there are big studies being collected looking into that, but the small studies I've seen so far, the right heart gets affected a lot. In the longer term, there's an incredibly interesting MRI data talking about microvascular dysfunction and the long-term effect, just like you were talking about, Ben, of the long-term effect of having COVID and on MRI showing microvascular dysfunction. And my guess is that actually, if we just looked in the critically ill, we're going to find this all over the shop as well. I think if you get sick, you've been on catecholamines, we smash your microvasculature. Our enthusiasm with trying to make sure that you got a map of 65 might sometimes be a bad thing, but yeah, we smash the microvasculature, and that can be causing long-term cardiac abnormalities. And yeah, COVID might show that. All right. Thanks very much, guys. Thanks very much, and I'll see you guys next time. Okay.
If you learned something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.